Hi, everyone. I'm Ryan Barmore. I'm a movement disorder specialist with Banner Health here in Northern Colorado. And I'll be discussing Parkinson's disease today, diagnosis, current, and potential future therapies. So it'll be a whirlwind overview. So to start with, Parkinson's disease remains a clinical diagnosis. There are no established biomarkers yet available. The MDS clinical diagnostic criteria have been used since 2015. And diagnosis begins by establishing the presence of cardinal motor manifestations of Parkinson's disease, like bradykinesia, with at least rigidity, one of either rigidity and or rest tremor. Motor Parkinsonism is a core feature of the disease. And so once we establish the presence of Parkinsonism, then Parkinson's disease proper as a cause of Parkinsonism is determined by looking at the absence of exclusion criteria, and the absence of significant number of red flags, and by the presence of supportive criteria. And the purpose of this is to basically rule out secondary causes or atypical causes of Parkinsonism other than PD. There's two levels of certainty: clinically probable Parkinson's disease and clinically established. So looking at the treatment framework that we use for Parkinson's disease, we still do not yet have any disease-modifying therapies, and treatment remains primarily symptomatic. So we manage symptoms of the disease itself as well as complications of long-term therapy. And both of these fall into broad categories of motor and non-motor symptoms. Complications can include motor symptoms, including delayed onset or shortened duration of medication action, incomplete response, as well as non-motor fluctuations, which come in a variety of forms: dyskinesia, drug-induced psychosis, to name just a few. So thinking about some of the more well-established medications for motor symptoms of Parkinson's disease, of which many of us are well familiar with, levodopa formulations remain the cornerstone of therapy, the oldest and most potent medication we have. Levodopa is typically combined with dopa decarboxylase inhibitors such as carbidopa, and come in a variety of formulations: immediate, controlled, extended release, intestinal gel, inhaled. We'll touch on that more in a minute. Dopamine agonists are synthetic small molecules intended to mimic the action of levodopa. Pramipexole, ropinirole, rotigotine, well-established. Apomorphine as well, more on that later. And then some supportive therapies: MAOB inhibitors, COMT inhibitors, intended to extend the duration of action of levodopa, broadly speaking. Rasagiline, selegiline, MAOB inhibitors have been around for some time, and tacopone and tolcapone as well. And then others with a smattering of a variety of mechanisms of action. Amantadine, typically used for management of dyskinesia, to some degree tremor. Anticholinergics, again, more for management of tremor. Clozapine, just to name a few. Brief note about deep brain stimulation and its place in our treatment framework. DBS is often considered in Parkinson's disease patients when optimized medical therapy fails to manage certain motor symptoms and or motor complications. And so the goal of DBS, like other advanced therapies in PD, is to maximize the time the patient spends at their best. So DBS does not improve patients' symptom control better than their best on state with medication, typically levodopa, and it does not generally treat symptoms unresponsive during the best medication on time. The one exception to that really is tremor. DBS is not disease modifying, and so our aims are then to reduce off time, increase on time, to reduce on time with bothersome dyskinesia, and to improve the control of tremor, broadly speaking. The balance of these aims will differ patient to patient. And so to talk briefly about a wave of newer medications, really in the last half of the last decade, we've had a number of newer kids on the block. So a variety of new levodopa formulations: extended release carbidopa, levodopa, Rytari, levodopa enteral suspension, Duopa, and a variety of medications intended to support Parkinson's off time and somewhat rescue therapy. So the newer MAOB inhibitor, safinamide, levodopa inhaled powder for rescue therapy, estradiol, a somewhat newer mechanism of action in this field, and the adenosine A2A antagonist, a newer COMT inhibitor, opicapone, dosed once a day as opposed to with every dose, as with the older formulations, and then a newer formulation of apomorphine as a sublingual film, somewhat recently approved. We've had a couple of newer formulations of amantadine in an extended release format for intention of treating dyskinesias, as well as droxidopa for treatment of orthostatic hypotension due to Parkinson's disease, and then a newer atypical antipsychotic, pimavanserin, approved in 2016 for treatment of Parkinson's disease psychosis. And so to briefly talk about some therapies on the horizon, I'm looking at a variety of newer formulations of older medications, as well as newer mechanisms of action, looking to the future to truly disease-modifying therapies potentially. We'll just go through a quick cross-section of some things that are currently in the pipeline to my knowledge. So there's a couple of formulations, subcutaneous infusion formulations of carbidopa-levodopa that are being investigated right now, a newer oral dopamine agonist being looked at as well. There's a variety of different agents looking at, just broadly speaking, management of oxidative stress and its role in neurodegeneration. So looking at this, an mTOR modulator under investigation, an interesting agent looking at reducing oxidative stress with the use of gold nanocrystals, an established tyrosine kinase inhibitor used currently in the treatment of chronic myeloid leukemia, nilotinib, being looked at in Parkinson's disease, a variety of other things, coenzyme Q10 analog, looking to reduce progression of prodromal Parkinson's to Parkinson proper, being studied in China, molecular hydrogen as an antioxidant, oral small molecules as well. So a variety of different things being looked at. So the future is hopefully bright. Immunomodulatory therapies are also being looked at right now. And a monoclonal antibody against alpha-synuclein, as well as an alpha-synuclein vaccine currently being investigated. Gene therapy looking at introducing the ability to convert levodopa to dopamine locally in the putamina, as well as a very interesting and novel approach using neonatal porcine choroid plexus cells to support and mitigate neurodegeneration. So there's other things out there. This is just a snapshot, other things on the horizon as well. But suffice to say, it's an exciting time to be treating Parkinson's disease, because I'm hoping that in the near future we'll have some paradigm shifts, but our armamentarium continues to expand. So thank you very much for your time.
Hi, I'm Jennifer Wright, physical therapist at Advanced Spine Physical Therapy in Fort Collins, Colorado. I'm here to talk to you guys about the benefits of referral to physical therapy for patients with Parkinson's disease. When referred to physical therapy for Parkinson's disease, there should be an assessment done initially to look at gait disturbances, balance disturbances, strength, mobility, rigidity, fine motor control, as well as caregiver role. With Parkinson's being a neurodegenerative disease that results in changes in motor control, all of these things are important to assess baseline so that we can keep track of how this patient is progressing over time in the months ahead, in the years ahead. It's important to assess and then educate. Patients with Parkinson's disease often don't have perception of the motor changes that are taking place, changes in walking, changes in ability to get in and out of a chair. And this initial education is sort of starting the beginnings of internal cueing, which can be a big factor in helping motor control be a little bit better for Parkinson's patients. One of the biggest roles as a physical therapist with patients with Parkinson's disease is getting them moving. Having a disease that creates difficulty in motor control often results in more time sitting, more time sedentary. It is our biggest focus to get people up and get them moving. And with the recent research showing that exercise is such a big component in helping to try to reduce the rate of progression or the rate of decline in motor control, it is so important to start that referral to physical therapy and getting them moving from day one, meaning day of diagnosis, or even prior to diagnosis, even with just the notice of change in motor control or motor function. Now, what kind of exercise? The newer research is actually showing that the best exercise for people with Parkinson's disease is the exercise that they enjoy the most, because that's what's going to be more consistent in what they're going to do. Now, are there other things that we should incorporate? Absolutely. But first things first, getting them moving. So if somebody loves getting out and walking, then encourage that. If somebody loves getting up and doing yoga in the mornings, great. Encourage that. Now, as far as exercise goes in physical therapy, there are three big things that we are really pushing and encouraging to try to help reduce that rate of progression. First, dual tasking. So cognitive loading on top of a motor task. So thinking about talking and walking, or counting and walking a straight line, balance board and singing. Again, dual tasking. So cognitive loading with a motor task. Second, we're looking for reciprocal training, which is something that is quickly lost with patients in Parkinson's disease. Reciprocal training meaning arms and legs moving at the same time. Maybe that's laying on your back, walking, crawling, running. It can be trained in many, many different ways and can be very successful in helping train both sides of the brain. And third, amplitude training. So meaning changing the way that they're thinking about how they're moving. That little tiny shuffling gait, or those little teeny steps that have become very small and are creating falls, we can create a scenario where they're increasing the amplitude of those steps to try to make that walking easier, to make that shuffling easier, to break the pattern of freezing when they're changing from one surface to the next. Amplitude training can be used in all parts of the body, whether it's lower extremity through walking and transfers, or in the fingers and hands, training to help with things like buttoning a shirt, eating. So again, three things we're really looking for in physical therapy for patients with Parkinson's disease are dual tasking, reciprocal training, and amplitude training. Now, that doesn't mean that you're not doing everything else. So they would benefit from strength training, entire body, lower body, trunk, and upper body, as well as balance training, challenging things like standing on one foot. Also making sure there's increasing mobility. Mobility in the hips and the spine gets so rigid and so immobile in patients with Parkinson's disease. It's so important to make sure that we're making sure they're moving as well as possible. And then also making sure you're really educating caregivers on how to encourage more movement and more activity. Now, when do we start this exercise? When do we start these activity levels? Immediately. We talked a little bit earlier about day of diagnosis, but it needs to happen as soon as there's any indication. And meaning if it's early onset and there's a diagnosis at early age of 46, we really need to start then. Lastly, it's really important that you're encouraging for these patients to get out in the community and do activities that may encourage them to even be even more active beyond what they're doing in physical therapy. That might mean including things like yoga, big programs, power programs, boxing programs, but encouraging that continued activity and that consistency throughout the week. Thank you guys for your time.
Hi, my name is LaGasse. I'm professor of music therapy at Colorado State University. Music therapy is the use of rhythm and music exercises that are individualized in order to reach non-musical outcomes and provided by a credentialed music therapist. CSU has been offering music therapy community group services for over a decade. These services focus on maintaining motor and speech functions in persons with Parkinson's disease. I'd like to tell you about 3 ways that music can help with treatment in individuals with Parkinson's. The first is gait. Music has a long history of helping individuals with their gait goals. Rhythm activates key structures that are involved with motor in the brain, including premotor, supplementary motor areas, basal ganglia, and the cerebellum. Many of these are affected in Parkinson's disease, and what we see when we add rhythm is due to the nature of rhythm being throughout the brain, that we employ compensatory mechanisms that allow gait to be more effective, and I'll tell you more about that in a moment. Let's first watch a video clip. You're going to see a gentleman with Parkinson's walking. Then you're going to hear music therapist Dr. Elizabeth Stegmuller singing a simple song And then in the third clip, you will see the individual walking while thinking the song.
Sleeping, I dreamt I had you in my arms. Sleeping, I dreamt I had you in my arms.
In this clip, we use a very simple musical application. We can also use external rhythmic auditory cueing in order to help individuals improve their gait. This is an inexpensive and effective method for improving gait in individuals with Parkinson's. Research shows that this leads to improved stride length and decreases in freezing. Recently, Harrison et al. Showed that internal cueing, or singing in someone's head, also led to improvements in gait, including gait velocity, cadence, stride length, and the ability to walk in the forward and backward direction. These effects are likely underpinned by compensatory brain mechanisms that may be contributions of the cerebellum, short-term auditory memory, or activations of cognitive networks in addition to motor and cerebellar networks. In addition to gait improvements, we can see improvements in overall exercise programs using music. This is an exciting and motivating way for individuals to participate in motor movement exercise. I'm going to show you a clip of physical therapist Ruth Rice and music therapist Sarah Johnson leading a motor exercise group for individuals with Parkinson's. It's several different movements, and you'll see how the music therapist is using music to help with the timing and overall progression of the movement.
And I'll tell you all
The impact of music for motor movement may extend beyond the motor benefits, with some evidence of benefits for cognition, mood, and language production. The third area I'd like to talk about is communication. Communication impairment is another common symptom of individuals with Parkinson's disease, which can affect quality of life. Singing shares many of the neural networks and cortical areas used in speech, and thus has the potential for therapeutic application to help with speech communication. I would like to show you a video clip of individuals with Parkinson's engaging in singing groups. What you will see is them engaging in singing for respiration, for articulation, and for overall volume.
Is all that I can give to you. Love is more than just a game for two.
In these clips, music therapist Sarah Johnson and myself are selecting music that will best help individuals to meet the goals that have been determined. Research on singing for individuals with Parkinson's has shown that it is a motivating way to maintain vocal function and build community. Stegmuller and colleagues were able to show that individuals with Parkinson's improved inspiratory and expiratory pressure and phonation time. Also, they observed improvements in quality of life measures. Champlin and colleagues showed that 3 months of music therapy group intervention helped with vocal intensity, maximum expiratory pressure, and voice-related quality of life in comparison to a control group. Overall, music therapy has been shown to help individuals with Parkinson's disease to improve in both motor and communication goals. Thank you for your time.